Hello folks, welcome to the radiology section of the E-class. The class shall begin immediately, focusing on radiographic anatomy as depicted on the panoramic radiograph or orthopantomogram OPG. Subsequent sections of the series will look at anatomy depicted on other extraoral as well as intraoral radiographs. Following the thorough review of the normal anatomy, each of the sections will then have a dedicated video lecture where we will have a look at a vast array of pathologies affecting the orofacial complex and how they may be represented on these radiographic images. I will leave the discussion about X-ray physics, hazards and precautions to the very end of the series. For today, our focus will be on the OPG or pantomograph, a common dental radiologic image that provides a big picture overview of the maxilla, the mandible, the entire dentition, and surrounding structures all on a single plain X-ray film. Although it provides less detail and accuracy than other forms of dental radiographs, it gives an initial idea about the presence of a possible problem and helps us in making informed decisions on a more appropriate investigative or diagnostic technique. Essentially, it is a screening tool to evaluate for pathology within the orofacial hard and soft tissues. The technique basically involves taking a number of sectional images or tomographs of variable thickness and magnification of the jaws and then displaying these sections on a single film for visualization and interpretation. The machine does these cuts during a 180-degree to 200-degree rotational movement around the patient's head. During this rotation, the patient is positioned so that the head is exactly in the space between the source of radiation or the X-ray tube head and then an image receptor or the film cassette. This space is where we will find the focal trough or image layer, and it is within the image layer that only certain aspects of the jaws remain in focus, while other aspects that are outside this layer or trough are blurred out. Let me repeat that again. Each aspect of the jaw has a focal trough where it is distinctly captured without distortion. Areas that are outside, either in front or behind the focal trough, are not represented. It is the final sequential alignment of these distinct focal trough images on the X-ray film that is observed following film processing. Now let me repeat myself yet again in another way, as simple as I can state. Imagine the OPG system takes 3 sequential images during its rotational movement around the patient. These 3 images will be the anterior aspect of the jaws and the left and right sides as well. Whilst taking the right-sided image, the anterior and left areas will be outside that image layer and so will be blurred out. In the same vein, during the imaging of the middle part, the right and left sides are blurred and not depicted. This follows through for the left image as well. Now, the distinct radiographic images as a result are now fitted together like a really simple puzzle on a single image receptor, the X-ray film, which then undergoes processing in the darkroom. The final image or radiograph will now have a right side, a central portion, and the left side. Now, this means that the single most important limitation for the technique is an error in positioning the patient correctly. For any clinically useful image to be produced, the patient must have the proper anterior-posterior relation and correct head alignment with the rotation center of the X-ray system. Also important is that the patient, after being properly positioned, must remain still while the X-ray system does its rotation, and this must be explained to him or her. Uncooperative pediatric patients may require the assistance of their parents or guardians. Patients must additionally remove all head and neck ornaments and intraoral removable appliances prior to the procedure. These precautionary measures are instrumental in helping to eliminate artifacts and secondary ghost images as much as possible and to ultimately increase the diagnostic value of the radiograph. The proper interpretation of the radiograph is only as good as the quality of the represented image. Alright, before we commence with the next phase of the discussion, it is important perhaps to acknowledge that there is a considerable wide variation in terms of what one might assume to be normal anatomy, especially when it is represented on a radiograph, and any one single image may not disclose all structural features or landmarks that should ideally be seen on a specific type of radiograph. To tackle this inevitable problem, as we go through this series looking at normal radiographs and those with pathologies, I will be constantly revising and pointing out to you the relevant regional anatomy as observed on different films. So now, we will start looking at some radiographic images, analyzing first all structures of normal anatomy. It is going to be as detailed as possible, and I will assume that you already have a good grasp on normal regional head and neck gross anatomy, and this discussion will really only be a do-over but from a different perspective. As we analyze these radiographs, we will follow a systematic approach so that we do not overlook critical findings that may potentially influence our overall patient management. This becomes essential when we start to look at the pathologies. Now, I'll begin with the mandible, then move on to the maxilla and midface, the dentition, and then the surrounding soft tissues. It is after we have gone through all the normal anatomy that we will be in a position to transition to panoramic radiographs that exhibit pathology. Now, look straight at this radiograph as though it was the actual patient facing you in the dental chair. By doing so, it wouldn't be confusing when I say this will be the right side and this will be the left side. Let us begin at the right side, starting with the right mandibular condyle or condylar process of the mandible. The condyle is convex shaped, and on the radiograph, it is the most superior part of the mandible, sitting within the concavity of the glenoid fossa on the underneath of the petrous temporal bone, and together both form the temporomandibular synovial joint complex or TMJ. Note that there is not a direct contact between the condyle and the glenoid fossa. A gap or space is left off and is bisected by the TMJ articular disc into an upper and lower compartment. Inferior to the condyle is the much slender neck of condyle, which connects it below to the ramus of the mandible. Anteriorly, the condyle is connected to the triangular coronoid process by a curved notch called the sigmoid notch, also referred to as the mandibular notch or mandibular incisor. This notch creates a space that leads directly into the infratemporal fossa on the medial aspect of the ramus. The superior border of this space is the zygomatic arch. The temporalis muscle passes deep to the arch to insert inferiorly on the coronoid process to help elevate the mandible. Tracing down from the posterior border of the condyle, neck and ramus, we come to reach the mandibular angle, which we will take as our reference point when we are compartmentalizing the mandible into the ramus region posteriorly and the body or corpus anteriorly. Similarly, tracing down from the anterior border of the coronoid process, we reach the corresponding retromolar depression on the anterior aspect. It is about from here that we see this thick continuation of buttress bone, the external oblique ridge, the inferior insertional area of the baxillary muscle, and is also an important landmark that becomes handy when performing a standard Halsted inferior alveolar nerve block. The ridge travels obliquely in an anterior-inferior direction. Now, back to the ramus. This structure here, seen roughly at an equidistant position from the margins of the ramus, is the mandibular foramen, the entry point of the inferior alveolar neurovascular bundle, the nerve, the artery, and the vein. The superior anterior lip of this opening is reinforced by this radio-opaque structure, the lingula, or what you might also call the spic spine, an attachment site for the sphenomandibular ligament. The inferior alveolar neurovascular bundle will pass behind this ligament and the lingula to enter into the inferior alveolar canal. The canal extends within the ramus and body of the mandible and just past the first molar to turn sharply upwards and anteriorly, coming out of the screen to emerge at the mental foramen located here, distoapical to the second premolar. Note that this exit position varies greatly. The rest of the canal continues down to the incisor region. Here I am showing the dense corticated borders of the canal, superior and inferior. Note that the names of these change within the ramus, with the superior becoming the anterior border and the inferior becoming the posterior border. The structures themselves do not change, just their names. Again, the spic spine or lingula will be located here. You will notice that within the body of the mandible, just apical to the molars, the borders of the canal have become much less distinct. This is because of a radiographically important anatomical depression on the lingual aspect of this region of the mandible, the submandibular fovea or fossa, the location of the deep portion of the submandibular salivary gland. This concavity should not be misinterpreted as a radiolucent pathology. The superior border of this fossa will be the mylohyoid ridge, a less thicker bone extension than the external oblique ridge. It is also the insertional site of the muscle that forms the carpet or floor of the mouth, the mylohyoid muscle. Superior to this ridge, you will find a more shallow depression, this time for the sublingual salivary gland, that is mostly superimposed by the molar dentition. Now, this is the inferior border of the body of the mandible. In the posterior region of this border, an upward indentation or notch has been impressed by the facial artery and vein. This antigonial notch is not easily discernible on this radiograph, so I'll demonstrate it on this next image. Here it is, just before the mandibular angle or gonion, the insertional area of the masseter muscle. So effectively, the facial artery and vein both course anterior to the anterior-inferior border of the masseter muscle within the concavity of the antigonial notch. It is from this point onwards that the body of the mandible begins, and then ending here at the parasymphysial line between the first molar and canine. At the inferior point of these arbitrary lines is a slight bulge that begins the symphysial or mental incisor region. The symphysis, previously located here, fused completely by the age of 2 years and usually leaves no evidence of its previous existence on radiographs. The incisor region is also the place to look out for interdental or nutrient canals, which appear as radiolucent lines coursing vertically through the interdental bone. These canals contain nutrient vessels to supply the bone, but will be more discernible on an intraoral periapical radiograph. Okay, at this time we have already looked at a depth of information on this radiograph, and at this point, let us take some time to recap what we have studied so far. We will do this revision intentionally on the left side of the radiograph. In practice, you will come to learn that structures that are bilateral are most likely going to be anatomic rather than pathologic, and so it becomes important to develop the habit of comparing right and left sides at all times. Again, try to correlate the radiographic anatomy with your knowledge of gross anatomy, because to be honest with you, the questions that will be asked in the advanced quiz section of this website will not be straightforward identification questions, but will be highly integrative. Anyway, let us quickly revise these structures, beginning with the left condylar head. The neck of condyle, mandibular incisor, coronoid process, the posterior and anterior borders of the vertical ramus of the mandible, the mandibular foramen, spic spine or lingula, inferior alveolar canal with the corticated borders, angle of mandible or gonion, antigonial notch, retromolar fovea, external oblique ridge, the faint mylohyoid line, the sublingual and submandibular fossae, the mental foramen, the arbitrary parasymphysial lines, right and left, and the midline symphysial line. It is important that when comparing the cortical bone, you assess and confirm that there is bilateral symmetry in the amount of bone thickness. For instance, the thickness of the inferior cortex apical to the right molar region should be roughly the same as that in the same location on the left side, and so on. You should also follow the cortical bone all round, checking for this symmetry, as well as ensuring there is continuity with no gaps or radiographic step deformities. I would like you now to take a deep breath, sit back at an arm's length distance to your computer screen, and have an overall eyeball scan of the entire mandible with your focus on the internal trabecular system. Though not very evident here, the mandible is about 80% compact or cortical bone and about 20% trabecular or cancellous. The trabecular pattern may be of a sparse architecture, dense architecture, or a heterogeneous mix of sparse and dense depending on the size of the individual spaces between the septations, so-called intratrabecular cells. This architectural pattern may change over the years in a person's life and may be a result of functional adaptation or from pathology. There is an 8-fold turnover rate when compared to the cortical bone, and this rate is highly influenced by metabolic and hormonal stimuli. For the most part, however, it remains relatively unchanged. Overall, females tend to have a more sparse trabecular pattern than males, with smaller amount and lower connectivity of the cancellous septations, and this is even more apparent in women during the postmenopausal period, owing to the general osseous decline during this stage of life. Therefore, sparse trabecular patterns do not always necessarily imply a metabolic osteopenic disorder. You will have to compare two radiographs taken at reasonably different times to be able to make that conclusion. Also useful to note is that the pediatric mandibles have even more sparse trabeculations, but this builds up gradually through the development of the mixed and permanent dentitions. Again, the most important take-home message here is to check for symmetry between right and left sides on the same radiographic film, compare current and previous images, and correlate all these findings with the clinical data you have to arrive at any meaningful conclusion. Now, these two structures located beneath the mandible are images of the midline hyoid bone. The hyoid bone we know is a single midline structure, but appears here to be bilateral because if you recollect from the start of the discussion, we explained that the OPG system captures the jaws from three aspects: the right, middle or anterior, and the left aspects. So it means that midline structures are clearly captured twice during the rotational movement, i.e. during the right and left capture times, and this creates what we call double images. These double images are as sharp as the real images and are a result of the equidistant position of that midline object from the X-ray film cassette during the entire exposure time. Essentially, a double image with respect to oral radiology is a pair of real images that is formed when an anatomical structure is situated right in between the rotation center of the X-ray tube head and the X-ray film cassette, but is intercepted and captured two times during the arc of one exposure. The hyoid bone, consisting of the body, greater horn, and the much less distinct lesser horn, is a good example to demonstrate this radiographic phenomenon. However, other structures to demonstrate this will be the epiglottis and the cervical spine. The main problem with these double images is that you cannot actually tell them apart from those structures that are in reality bilateral, such as the styloid processes. In other words, bilaterally occurring structures also occur double, but whereas there is a right and left styloid process, the hyoid bone in reality isn't bilateral, despite its misleading appearance on the radiograph. Hopefully, this should hammer home the reason why it becomes pertinent that the radiograph be interpreted taking into consideration the regional structural gross anatomy. Now, it is true indeed that these midline structures are captured from the front as well, but it turns out that from this perspective, they are usually blurred out and mostly distorted and rather become a nuisance as they superimpose over the more relevant anterior regions of the jaws. We can see evidence of this here, where the distorted image of the cervical spine obscures the sharpness of the anterior mandible. This blurry distortion is what we refer to as a ghost image, and together with the related double images, we collectively term them as a triple image. So effectively, ghost images, double and triple images, are not true representations of normal structural anatomy. I hope this is clear, as you will need this understanding moving forward in the discussions.